Thank you. So I'm a heart surgeon, and essentially what we're going to talk about is the goals of therapy in mitral valve regurgitation and how one can go about choosing whether one does surgery or whether one does a catheter therapy. And we're going to focus mainly on degenerative mitral regurgitation. Dr. Stone has already really summarized all there is to say about functional regurgitation. So there are two questions to ask if you have a patient with severe mitral regurgitation when you're contemplating intervention. The first is you've got to ask what is the clinical goal of the mitral valve intervention. And we're talking about the clinical goal, not the echo goal. So it's not about whether you're going to reduce regurgitation or remodel the left ventricle, it's what the patient intends to benefit from the procedure. And there are essentially four different categories that the benefit would fall into. The first is to provide relief from acute illness. You have a patient who is in severe pulmonary edema or very crippled and you want to make them better. Or it could be to provide limited palliation, a patient who you know that their life expectancy is limited and then you just want to provide them with some palliation, and most functional patients will fall into this category. You might want to prolong their life expectancy, like a 45-year-old with Barlow's disease, you want them to live till they're 80. Or you want to maintain or improve quality of life over a long period of time. And I think it's important to work out in your mind which of these, sometimes it's more than one you're trying to achieve, because that determines what you do. Because if your focus is on acute palliation, then really what's important is the short-term outcomes of the procedure you're planning to do. Whereas if you're thinking of long-term life expectancy, or long-term quality of life, you have to think of the long-term effectiveness of the procedure you have to do, as opposed to the safety and short-term outcome. Then once you've answered the first question, the second question you've got to ask is whether the treatment you're proposing gives the patient a realistic chance of achieving the goal that's set to be achieved. And if you can't achieve the goal, then your treatment is probably going to be futile. So the key thing to think about with mitral regurgitation is that most of the benefits that come with treating mitral regurgitation occur in the long term. What you saw in COAPT is an exception with functional MR, but with primary MR, which is the main focus of my discussion, most of the benefits come in the long term because mitral valve disease is rarely associated with sudden death or sudden deterioration, unlike aortic stenosis, for example. So, for example, if you look at this series from the Mayo Clinic, comparing early surgery and medical management, the curves didn't start to separate till about 2 to 3 years after. So if you're looking to test a treatment for degenerative mitral regurgitation, there's no point doing the test and looking at 1 or 2 year outcomes, because the benefit of therapy doesn't come for several years. So you have to consider essentially two attributes. You've got to decide in your mind, is the short-term outcome more relevant? And if the short-term is more relevant, such as the functional patients Dr. Stone talked about, because the early death rate is quite high if you have functional MR and heart failure, then you're looking for a procedure with lower risk, a procedure that has known effective short-term outcomes, so something that works in the short term. You're looking for something that will just address the mitral regurgitation. You don't think much about other problems the patient might have. And this is the ideal testing ground for investigational devices, new catheter therapies, whether replacement or repair. Whereas if the long-term effect is more relevant, so you have a 50-year-old with degenerative mitral regurgitation, then you have to accept the trade-off and accept a higher early risk if necessary, if that's going to give you a long-term benefit, i.e. surgical treatment. You look for treatments that have either known durability or expected durability. So if you can logically expect a new investigational treatment to last a long time, then surely you can use it. Then you should consider approaches that treat the entire spectrum of disease. So if the patient also has aortic stenosis, also has coronary disease, you want to treat everything in these patients. And you should consider established procedure. So really the question then arises, what is it that we're comparing to? So if you're going to try and push a catheter treatment for degenerative regurgitation, what are you comparing to? What is surgical state of the heart? And I'm going to focus on this one paper. This is probably the surgical paper with the longest follow-up, just published in JACC 2 months ago. And this is from Tyrone David's group. So patients he's operated on since 1985, about 1,200 patients, and he followed them up, and in the Canadian system he has very good follow-up, and he reported on the outcomes. we were asked to write an editorial, which myself and David Adams wrote, that accompanied this paper, and that's going to be the focus of how we're going to look at this paper. So the first thing we noted from Tyrone Davis' series that if a mitral valve repair is done well and done by an expert, it's very durable. And indeed, at 20 years, only 12.5% of patients had recurrent regurgitation. So without question, for the vast majority of patients, mitral valve repair works and will work. But the concerning thing in a series that despite the fact that most patients had the mitral regurgitation eliminated, cardiovascular events were very common after mitral valve repair in Dr. Davis' series. And indeed, if you looked at 20 years after, only about 60% of patients were free from either death, reoperation, or reoperation. He didn't actually look at freedom from major adverse cardiac events, but if you read through between the lines, you see that at least half the patients had a major adverse cardiac event. And that brings the question as to why do these patients die despite having competent valves? So almost half the patients died in 20 years, but most of them had competent valves. And I think that brings us to the other issue, which is that despite the fact that you get rid of the mitral regurgitation, patients still had cardiovascular events. For example, thromboembolism, almost 15% of patients had developed thromboembolism despite a competent mitral valve repair 20 years after surgery. Or tricuspid valve regurgitation, 20 years after surgery, about 20% of patients had developed severe, moderate or greater tricuspid regurgitation. So despite having a competent valve, on the mitral side, the tricuspid valve started to leak. And we all know that tricuspid regurgitation is a negative prognostic factor in the long term. Or atrial fibrillation. This was even a more surprising finding. About a third of patients by 20 years had developed atrial fibrillation. These were patients who didn't have atrial fibrillation at the time of surgery, and they developed it later. And we believe that these are the factors that are causing the higher death rates in patients despite having successful mitral valve repair. So what's the clinical implication? Obviously, we have to try and operate on patients earlier, because in Tyrone's series, as you can see on the top left-hand graph, if you were operated when you were in New York Heart Association Class 1, your long-term outcomes were much better compared to patients with more advanced disease. But the other question arises as to whether there are things we can do with the atrial fibrillation, tricuspid regurgitation, other factors that might impact long-term outcomes. And we believe that we should then relook at the way we manage mitral valve regurgitation and look beyond just fixing the regurgitant valve. So we want to get rid of MR, but we also have to start thinking of thromboembolism. We have to start thinking of how we manage the atrial appendage. We have to start thinking of medical treatment, anticoagulation. We have to think about atrial fibrillation. There's a question as to whether we should start doing clinical trials to look at whether there are prophylactic pharmacological or surgical maneuvers we can do that might help prevent late atrial fibrillation. Tricuspid regurgitation is an important target for us, and certainly in our institution, we have a very low threshold for addressing the tricuspid valve and performing tricuspid annuloplasty. And as we move into the catheter treatments, if we're doing isolated catheter mitral valve treatment, we will find that there will be a lot of tricuspid regurgitation coming later on, so we have to think the tricuspid valve. Quickly, functional mitral regurgitation, is there still a role for surgery? We don't have data that shows surgery is better than medical therapy. We've heard the data from COAPT, and so we know the percutaneous therapy is better than medical therapy. There's no head-to-head comparison of surgery versus clip therapy. And interestingly, most of the mitral valve replacement trials percutaneously are focusing on functional patients. So the reality is that as surgeons, we lost our opportunity to provide data on the utility of surgery in functional mitral regurgitation. It's unlikely that we will ever provide that. So I think functional mitral regurgitation, except in selected patients, will be a catheter-based treatment, and we'll never know the true effectiveness of surgery. So in summary, so you ask the two questions: what is the clinical goal of the mitral valve intervention? If it's to provide relief from an acute illness, you're looking at short-term outcomes, short-term risk, you want a catheter treatment. Surgery, if it's feasible, but catheter. If you want to provide limited palliation, you have an 80-year-old, you just want to give her some quality of life at home, catheter. If you're looking at life expectancy, young 20-year-old, surgery. And if you're looking to maintain or improve long-term quality of life, surgery. And if you have catheter trials, you want to focus on the patients in the first two groups and not the latter group. And certainly, for surgery especially, we should focus not just on mitral regurgitation, but on minimizing tricuspid regurgitation, minimizing thromboembolism, and minimizing atrial fibrillation. Thank you very much.